Welcome to our Primetime Alive program on atrial fibrillation, what you need to know. I'm Vicki Newell. I manage the Primetime Alive program here at Mary Greeley Medical Center. If you need more information or you want to join Primetime Alive, you can join us at mgmc.org/PTA. Our presenter today is Dr. Esteffania Villegas. Dr. Villegas completed her medical degree at the University San Francisco de Quito in Ecuador, a residency in internal medicine at Mount Sinai Hospital in Chicago, and a fellowship in cardiovascular disease at Rosalind Franklin University at Mount Sinai Hospital in Chicago. She joined McFarland Clinic in October 2023. Please welcome Dr. Villegas.
Thank you. So we're going to talk a little bit about atrial fibrillation. This is a very common disease, and we are more aware as the years pass because we have more diagnostic tests, we are more aware of it, and we know also how debilitated it can be if left untreated. So the burden of the disease, it is a very common disease. In 2020, there were 50 million of existing cases in the world, which is a lot. There are some lifetime risks associated with race directly. So white individuals have 30 to 40% more risk, African Americans 20%, and Asian individuals 15%. Atrial fibrillation increases the risk of having other diseases, 5-fold for heart failure, 2.4 for stroke, 1.6 for kidney disease, 1.5 for cognitive impairment or dementia, and 1.5-fold increase for myocardial infarction. So that is why it is very important to be aware of it and treat it appropriately. Atrial fibrillation doesn't discriminate. Mr. President has atrial fibrillation, Billie Jean King, Ellen DeGeneres, just to say some people that are very famous. So what are the risk factors for atrial fibrillation? We have some risk factors that we cannot change. There's nothing we can do about them. Like age, male sex is more in a risk factor for atrial fibrillation, family history of atrial fibrillation, some genetic disorders like congenital heart disease. So these are things that we carry them and there's nothing we can do. There are other risk factors that we can modify ourselves, like alcohol intake, sedentary lifestyle, and smoking. These are risk factors that are very well known and that we can do something about them. And there is another set of risk factors that we might need a little bit of help to get them under control. Obesity and losing weight, high blood pressure, diabetes, heart failure, disease of the coronary arteries like previous heart attacks. Some cardiac surgeries are prone to have atrial fibrillation afterwards, like valve replacements, for example. Sleep apnea and thyroid disease. Sleep apnea is a big thing right now. It has been underdiagnosed for years, and now we have better machines like CPAP machines that we can use, and it's very much related to the risk of atrial fibrillation. We don't have a very clear study saying that controlling the sleep apnea will cure atrial fibrillation, but at least we know that taking care of sleep apnea decreases the events of atrial fibrillation. So what is atrial fibrillation? Here you can see a normal beating heart. The electricity comes from the upper chamber and goes to the lower chamber, and we get a nice rhythm. All these spikes are the heartbeat, and they are the same shape, the same space between them, and they have this little blip before, which is the normal pacemaker of the heart, and that's what we want. That's what we want our heart to look like. In atrial fibrillation, there is electricity coming from the upper chambers of the heart, most likely from the left side, that's overriding the normal pacemaker and making the heart not have a good contraction, a good and synchronized contraction, but more like a vibration. And this irregular beat gives us these beats which are different size, different space between them, all irregular, very unorganized. And we don't see the normal pacemaker of the heart doing the job, because that electricity is just too much and it's overriding the normal pacemaker. When this happens, when atrial fibrillation happens, the vibration of the heart makes the blood to get a little bit more stationary in different chambers of the heart, especially in the left atrium. There's a little piece called appendage where the blood can deposit, and if it stays there too long because there's not an effective contraction, it can cause blood clots, and that's how the strokes are produced later on. What are the symptoms? So sometimes people don't feel anything, and they are in an irregular rhythm with atrial fibrillation. But most commonly, people feel chest discomfort. It can be pain from tightness or just like something funny in their chest. A lot of people complain of fatigue or having less energy to do things during the day. Palpitations is a very common symptom, and people describe this as a fluttering sensation of the chest, as feeling like a racing heartbeat, or feeling like the heart is beating harder and then skipping beats and then beating harder again, just like abnormal. Some people complain of dizziness, lightheadedness, shortness of breath, or decreased exercise tolerance. So whatever they were used to do before, walk for 10 minutes or walk for 30 minutes, then they can only do it for 5, or they can barely walk inside the house. And sometimes also it just happens that because the contraction of the heart is not very effective, they have fainting episodes. The blood is just not enough to supply the brain, and then they're just like, boom, fainting. How do we get a diagnosis of atrial fibrillation? So we start with some blood work to check basic things like the kidney function, electrolytes, potassium and magnesium are always very related to the heart. We also check thyroid function because we know that it's related to atrial fibrillation when the thyroid has some disease. And we also check for blood count to see if there's anemia or anything that's speeding up the heart for any reason. Chest X-ray is something basic that we do just to make sure that there is any lung disease or any scars in the lungs that can promote atrial fibrillation. And the most important thing is to document this irregular rhythm with an EKG. Sometimes we can, sometimes we cannot. We also get an ultrasound of the heart, an echocardiogram, where we check the structure of the heart and the function of the heart. We check specifically for how big is the left atrium, the left upper chamber of the heart, because when this is dilated, it's more prone to trigger extra electricity. Sometimes we cannot record on an EKG an irregular heartbeat. Sometimes the episode is too fast that until we connect everything, it's gone. So then we use heart monitors. The most common heart monitor is the Holter monitor. We use this for 24 hours or 48 hours. It's not very comfortable. There are some wires going around and you have to carry that little cell phone in your pocket. It's not the worst, but it's not the most common. The most comfortable, sorry. And then we have shorter monitors like these two. This is a Cyopatch or a Bardicam. These are like stickers. They stick to the chest and we leave them for a week or 2 weeks. And they both have these tiny buttons that you can press when you feel the palpitations or whatever symptom you're feeling. And this machine will record all the heartbeats during that time and also the ones that were pressing the button because of symptoms. And sometimes, even with that, we cannot say for sure that somebody has atrial fibrillation. We cannot catch one of the episodes. So then we use long-term monitor. This is like a USB kind of thing. It's small. It is 1¾ inches. It goes underneath the skin on top of the heart. And we can leave this in there for 3 years. The battery lasts 3 years. And we check it regularly just to see if we find some episodes of atrial fibrillation. And then to go farther on workup, we also get some stress tests because we want to know if we can trigger atrial fibrillation with some stress on the heart. So we can either do exercise stress or pharmacologic, use some medication to induce stress in the heart, and the patient feels like they are running a marathon. They are running like a very fast pace, but we are inducing that with medication. If we can exercise, we do treadmill. All the time, we monitor these tests with an EKG. And then we do some pictures, either an echocardiogram at rest and then after stress, or we do a myoperfusion study. This is, we inject some radioactive tracer that colors the heart, and we take pictures like with a CT scan machine before and after the stress and see the difference. If there's any different colors of how much the heart is uptaking, we can suggest that there are blockages in the arteries and there's less blood flow to one side more than the other. How do we treat atrial fibrillation? So it is we have like multiple approaches that we have to take into account to treat atrial fibrillation. The most important one and the main one is stroke prevention. So when somebody goes to the doctor, we use a very well-known score to predict stroke. This is called the CHATS-VASc. It counts the risk factors for having a stroke: heart failure, high blood pressure, age that we can't do anything about, diabetes, history of a stroke, minor stroke, or blood clots in the legs, in the lungs, anywhere, vascular disease like heart attacks in the past, or aortic plaque or plaque in the legs if we have some. We give 2 points for age above 75, 1 point for 65 to 74. And of course, females, we always win the lottery in medicine, so we get 1 extra point just because. So if we have a low risk of stroke, means if a male has 0 points or a female has just 1 point for being female. So this means that the risk of a stroke in a year is 0.2% if it's 0 and 0.6% if it's 1. So we talk about what can we do to prevent a stroke. Sometimes we choose to do aspirin, not a full blood thinner at that point. When we are in the other side, where the risk is moderate to high, and that means more than 2 for males and more than 3 for females, so 2.2 risk up to 12%, we definitely recommend anticoagulation. Anticoagulation, unless some other things happens, that we will come back to that. In the middle, we always discuss what's the risk and the benefit. Like if we have a lot of bleeding because of falls, problems with balance, we might say, well, we can kind of watch it and do aspirin instead of full blood thinner. Or if we are safe and we don't have any major bleeding problems, we can just go for the blood thinner just to prevent the risk of stroke. We don't want a stroke to happen because it can be very debilitating. A stroke can be something like somebody cannot talk for a few hours until one of these blood clots goes away from the arteries in the brain, and then it's resolved and this person goes back to the normal life. Or it can be not moving half of the body, not being able to talk, or not being able to understand even if he can talk. So it can be very, very debilitating, and that's why the main objective that we have in treatment is to prevent stroke as much as we can. So what do we do? Oral anticoagulation. Some of you have heard about warfarin, is the oldest blood thinner. It requires a lot of monitoring. We have to check the blood every week, every 2 weeks. The new ones are Xarelto, Eliquis, Pradaxa. These are newer anticoagulations, work in a different way. We don't need to check the level, and all of these have some medication that can revert the action of the blood thinner if we have like an emergency and we need to do a surgery, or if there's a major bleeding and we need to just go back to not being anticoagulated, we can do that with medication. Sometimes people cannot take pills for some reasons or because of other medical conditions, and then we use injectable blood thinners. These are pre-charged syringes that come in the pharmacy just like the pills, and people inject them themselves. It's not very nice, but we have the option. And then sometimes we cannot use any medication because of bleeding, because of falls, because of some other issues, other medical issues. And then what we do is we do some devices or surgeries to prevent the blood clots. So this is the left atrial appendage that I was talking about. This is the left upper chamber of the heart and has a tiny thing hanging there like a little ear. This is where the blood mostly gets stuck when the heart is in atrial fibrillation and where blood clots can form. And then as soon as the heart has a good squeeze, a good heartbeat, it can dislodge up to the brain. So this is one of the latest devices. It's called Watchman device. It's like an umbrella. So we go in with a catheter from the leg up to the heart. We cross in the middle of the two chambers and deployed this device in that side. So far, the results have been very good. It is a procedure, it is an intervention, so if we can just don't do it, we don't, but sometimes we have to. So then another part of managing atrial fibrillation is rate control. This means controlling the speed of the heart. How fast is the heart going? And for this, we have different medications. Beta blockers are the most common ones and the ones that we normally start with. Some examples are metoprolol, carvedilol. Probably you've heard about those names. Calcium channel blockers is another medication that we can use. One of the most common ones is diltiazem. Digoxin is a very old medication, and it was used for different things, including heart failure. And we also use this digoxin when we have problems controlling the rate, the speed of the heart with this other medication. It is a medication that needs a lot of monitoring because it works directly with the kidneys and the potassium. So any changes in the potassium can cause the level of this drug in the body to go either too high or too low, so it could be effective or toxic. So that's why we have to keep a close eye, and that's why we don't start with this medication. Sometimes atrial fibrillation doesn't go fast, it goes slow. It's an irregular beat, but very, very slow, because the pacemaker, the natural pacemaker of the heart, that cannot keep up with the electricity there. So when that happens, to control better the atrial fibrillation, we put a pacemaker. We don't use this very frequent, but it's something that sometimes we have to use. A pacemaker is a little battery that goes underneath the skin, and it has wires that go along inside the right chambers of the heart, and they are connected to the muscle. So they give a little electricity, a little impulse, and the heart beats at the rate that we set for the pacemaker. So that's something that sometimes helps us to control the speed of the atrial fibrillation. The next step in the treatment is rhythm control. So now we're talking about putting the heart back into this normal sinus rhythm, the normal heartbeat with the normal pacemaker driving the heartbeats. So we have pills, of course, for this. Most common names, amiodarone, sotalol, dofetilide, flecainide. This medication acts in the different cycles of a heartbeat to try to get the heart back to the normal rhythm and keep it there. So sometimes we use this in combination with other strategies, but medication sometimes takes longer time to control than other things that we will talk. And all the medication, even aspirin or the most mild Tylenol, has side effects, so these medications as well. So if we need to use them, we do, and we monitor a lot of things closely. And if we can avoid them, we're glad to avoid them too. Other strategies to control the rhythm or to put the heart back into the normal rhythm are these procedures, TEE cardioversion. TEE is a transesophageal echocardiogram, the same echocardiogram that we did to check what's the function of the heart, but we're taking the picture from the inside. So what we basically do is we put a camera through the mouth inside the feeding pipe, and with the camera we take pictures directly from the back of the heart. We're trying to see specifically this appendage, the left atrial appendage where the blood can get stuck. We take pictures of this, we measure the velocity, we put color on it to see if there's anything there. And if there's nothing, we take a quick look at the rest of the heart, but if there's no evidence of blood clots, then we take this camera out of the body, and the patient is already connected to these pads you've seen on TV shows, and we give a shock, an electric shock to the heart. We restart the heart like that. So we go from having an irregular rhythm in atrial fibrillation to having a normal rhythm afterwards. Sometimes Together with this, we need to give some antiarrhythmics just to keep the heart in that rhythm. But this is kind of where we start when we try to put the heart back into the normal rhythm. Another procedure that we have to put the heart back into the normal rhythm is an ablation. This is a much complicated procedure. This procedure is under anesthesia. The other one is with sedation only. This is a procedure that is done by another subspecialty doctor in cardiology called electrophysiology, the electrician of the heart. So what they do is they put a catheter in the groin and they go up all to the heart. We cross the middle septum of the upper chambers, and then with one of the catheters, we map the heart to see where is the electricity coming from. And with the other catheter, we kind of burn the tissue where the electricity is coming, so it cannot produce any more electricity, and we cure, in quotes, atrial fibrillation. It is a successful procedure, about 85 to 90%. Nothing is perfect. So sometimes we can have some recurrent atrial fibrillation even after having an ablation. And then at last, we have risk factor management. And this is kind of the most broad way of treating atrial fibrillation. So lifestyle modification is very important. Exercise, especially cardio workouts, not too much weightlifting, is very important for the heart. More so when the heart is going fast. Exercise helps the heart kind of retrain and know when we're exercising, we want the heart to be fast. When we're resting, we want the heart to be low rate. So the heart knows the difference between that and doesn't go crazy just because. The other thing is weight loss. Smoking cessation is very important. Alcohol, avoid alcohol. So the recommendation is less than 8 drinks in a week. And a week is 7 days, okay? Because people are like Monday through Friday, yes, less than 8. Heart healthy diet. General recommendation, heart healthy diet means chicken, fish, turkey, better than beef and pork, including vegetables and fruits with the meals, and drinking mainly water, some juice every now and then, but mainly water during the day. Treating all the other medical conditions, having high blood pressure under control all the time, good management of the diabetes, having the thyroid under control, and taking care of all lung disease, COPD, asthma, fibrosis, anything related to the lungs. Avoiding triggers of atrial fibrillation, for example, high levels of stress, and that's something that sometimes we cannot control, but high levels of stress can put the heart back in atrial fibrillation after the procedures or after medication. Lack of sleep is another one. Excess of caffeine, especially people that drink energy drinks that are like 200 milligrams of caffeine in one tiny volume. Dehydration, that's why water is very important, and sometimes, especially in winter, we all forget to drink water. We don't feel thirsty, and we just go with our day with no water at all. And then sleep apnea. One more time, we have different devices for sleep apnea. The most important thing is to suspect sleep apnea in somebody and then treat it appropriately, either with a CPAP machine. AutoPAP, this is continuous positive airway pressure. So the machine pushes air inside the nose and the mouth of a person to open the throat so it doesn't snore at night. But most important, the oxygen doesn't drop at night and doesn't put a pressure on the heart every night, every time they snore. There are also some dental appliances that we can use. They are not as effective, but it's an alternative when people cannot use CPAPs for any reason, including being claustrophobic. This is the main things about atrial fibrillation. This is my favorite mountain from Ecuador. Questions?
It's beautiful. What is it? Is it that Cotopaxi, or how do you?
Yes, Cotopaxi. It's a volcano.
It's a volcano. How big? What is the population of Ecuador?
13 million.
Oh, goodness. Okay.
Yes.
Very good. All right. Raise your hand if you have questions. I will come around with the microphone so that everybody can hear what is being asked. All right. Coming down.
You see a lot of these wrist watches, or whatever you want to call them, that test for atrial fibrillation. Are they effective, or?
Apple Watch, Samsung Watch, those kind of things.
Yeah.
Yeah, they are very accurate. I think that for people that just want to monitor themselves, it's very good. They are accurate on giving an alarm when their heart is irregular. When we know already that somebody has atrial fibrillation, I don't recommend them too much because people get very anxious about checking every time. And that can actually increase the stress level and put them in atrial fibrillation. Right. So once we know, I rather don't use them, but just to monitor without atrial fibrillation, they are very good.
And I'm assuming that those watches have where you could turn that function off.
Yes,
too,
for
so
sure.
You're not, right, exactly. It is amazing what those watches can do, but good things, but they can also create more problems.
Yes.
So, yeah. All right, other questions? Okay, one more back here.
Could you comment a little bit about the success rate with the TEE?
Yes. So TEE cardioversion is a very safe procedure and very common procedure. The success rate is about 90%. What we take into account before doing a TEE cardioversion most of the time is the size of the left atrium. If we see that the left atrium is already mildly dilated, we might have a success of 80%, 85% to 90%. If we see that the left atrium is severely dilated, the success rate is very much low, like less than 30%. So at that time, we tell the patient what are the success rate and what's the benefit to try, but it's not like a guarantee that we will convert the patient back to the normal rhythm. And also sometimes, even if the left atrium is mildly dilated, but we have other problems like untreated sleep apnea, the cardioversion can be effective at that time. But then in like 2 days, they go back into the atrial fibrillation because of the other reasons.
Okay, so I feel like I hear more of
Another
people.
one.
Oh, where is that?
Down here.
Down here. Okay, as I'm going down, I'll ask my question. I feel like I hear more of more people being diagnosed with atrial fibrillation. So is that A, I'm getting older, my friends are, and so I hear it more? Is it B, are there things happening in our world that more people are? Or is it C, maybe we've learned more and better diagnosing and all that stuff that we're just identifying it more?
I think A and C.
I'm getting older and...
Yeah, I think that there is more awareness about atrial fibrillation because of the damage that it can do if it's left untreated. And also because we have better diagnostic things. Before, the Holter monitor with all the wires was the only way to monitor the heart, and we were using that for 3 months or whatever time we needed. And people were like, I'm not going to wear this for that time. So we couldn't catch anything. With the smaller patches, for example, we wear them for 2 weeks. We can do for another 2 weeks afterwards, and we catch an episode and we're done. We have a diagnosis and we know what to do. So I think it's a combination.
Okay, thank you.
The gentleman mentioned, I think, something about the wrist device. I've got the little Cardia with it works with the phone. What do you think of that? How accurate is that?
It is very good. It is accurate. The good thing about Cardia also is that you can link it to an email for your primary doctor, for example, and people can get your readings. The bad part of that is that when you feel something, you have to take your Cardia out, put your fingers, open the app, and sometimes the episode is gone. So it is good, but it takes a little bit more time to get the reading.
And that is called Cardia?
Cardia with a K.
With a K. And it's a device you have to get out, put your fingers on. Whereas,
and there's an app, yeah.
Whereas it does kind of the same thing as what your watch would do, but you're already wearing it.
It's a little bit more precise, the Cardia. It's a little bit more accurate.
I think I've seen those before, but okay. All right, but that's a good point. It could pass by the time.
Yeah, one of my patients was telling me that her episodes last 10 seconds. So she's like rushing to get the thing out, and then it's like, it's gone. It's like, no, I can never catch it, but I know I have it.
So you said that age is a risk factor. At what age do you generally see people being diagnosed with AFib?
That's a good question because it varies a lot. So more than 70 is more common, but starts like around 60. And the age is like very important because of the score for anticoagulation. So before 64, we don't have that as a risk factor for having a stroke. After 64, we do. So it's even more if it's after 64, like more things to count.
But you can still get it before the age of 60 as well,
you can
right?
still,
Okay.
yes.
All right. Excuse me. Other questions? Oh, I got one in the back. You guys are helping me get my workout in today. Thank you.
Cardio. At one point, did you say people with AFib are more apt to fall? Or their balance or something?
No. It's not related like that. But sometimes people with the irregular heartbeat, because of the atrial fibrillation, have this dizziness that causes imbalance, and then they can have an episode of fainting. But it's not like AFib causes this imbalance. It's just the symptom of not having a good heartbeat and the blood circulating properly, just like this shaking motion is not efficient enough.
All right. Tim, are there any questions online?
No questions online.
All right. Here's your last chance. I know somebody has a question they want to ask. We have time if we have another one or two. No? Oh, yep. 1 second.
So you said at the point of trying to control the rate that you could possibly do a pacemaker. At what point would you do a pacemaker?
We only do a pacemaker if the atrial fibrillation, instead of going fast, is slow. So we have a slow heart rate in the irregular rhythm. So we were trying to control the rhythm of the heart. The medication that we use most of the time decreases the heart rate further. So we can use anything. So then we put a pacemaker so we can set the heart rate at the level that we want, let's say 60 beats per minute, and then we can use medication to control the rhythm of the heart better.
Okay. My dad has AFib, so that's why I'm here. And if you're telling me that it's family related, it's probably a good thing I am here.
Right.
She brought up a question. If a person has bradycardia, is this, I assume it's a greater risk if you have AFib then, right? If it develops?
Not necessarily. Bradycardia can be related to the natural pacemaker of the heart getting old, getting like just aged. So sometimes we can do some things to kind of treat that, but other times we just need a pacemaker because the natural pacemaker is already not working.
All right, so I'm down front. I'm guessing somebody in the back row has a question. Yeah, we do. How did I know?
We got together.
So you planned all this, Rich, huh?
Okay, a scenario. You had a TEE and it was unsuccessful. At the time, you were not known to be sleep apneic. A year, 3 months later, you're diagnosed with sleep apnea and you go on CPAP. This started in 17, okay? So you're doing well with the atrial fib, you're controlled with Pradaxa, beta blockers, and all that. Is it ever possible to go back and have another TEE?
Yes.
Okay.
Yes, and most of the time what we do is we use an antiarrhythmic before the procedure so we can have a little bit more success in keeping the rhythm, in the normal rhythm after the cardioversion because we already load the heart with some antiarrhythmic medication. But yes, we can do it.
Okay, thank you.
Wow, so interesting, isn't it? What you can do these days?
Shocking hearts with electricity?
Yeah, exactly. All right, here's your last chance, everyone. Making my way down. Any other question? Do you have? Okay. Do you? Yeah. All right.
You mentioned putting a pacemaker in to control the rate. you set it at a certain rate. What happens if the person starts exercising and the pulse rate, can it go up with the pacemaker?
The pacemakers are very smart. They are like little computers. So we set two different rates in the pacemaker. We set a lower rate and an upper limit rate based on the age and how much exercise a person has. So for example, if a person is youngish, needing a pacemaker in their 50s, we can set the pacemaker 60 to the baseline and maybe 140 to the upper. If the patient is more in the 70s, 80s, we can set the lower to be 60 and the upper to be 120, 110. And there is a specific mode in the pacemakers that we can set up that if the person goes higher than the upper limit with a normal rhythm, so the pacemaker knows what's a normal rhythm, it can let it go for, let's say, 30 minutes, 15 minutes, and then do something about it. So they are very, very smart.
Okay, so Rich, which age group are you in? 25. All right.
I got a bridge for you.
All right. Any other questions? No? No? Well, wonderful. Lots of great information, Dr. Villegas. Thank you so much for coming today, presenting this information, taking time from your afternoon. We all really appreciate it.
Thank you for having me.
Yeah. And so I just want to let those of you know our next program, we actually have next Wednesday, March 6th in this room, 2 p.m. It's over-the-counter medications and older adults, everything you need to know. And then Thursday, March 28th, we have a program, What Goes Wrong with the Urinary Tract? So we also have our trip to Pella coming up Tuesday, May 2nd for the Pella Tulip Festival. We have 5 seats open. So if you're interested and still thinking about it, I would probably sign up today. I have some registration slips up there if you're interested. But thank you for coming out, everyone. Thank you for joining us online, and enjoy the beautiful weather that's coming up. Thank you.